Olá pessoal, estamos aqui na nossa cobertura da AUA. Acabamos de sair da sessão de pódios, uma sessão muito interessante sobre vigilância ativa. Estamos aqui com o Dr. Sanoj Punnen, full professor da Universidade de Miami, e ele acabou de concluir um trial. O trial se chama MAST, Miami Active Surveillance Trial. Eles basicamente seguiram pacientes durante 10 anos em vigilância ativa. Eles acabam de sair os resultados agora e apresentaram aqui na AUA sobre o papel da ressonância. So, Dr. Punnen just presented the results of the MRI, and you had the opportunity to biopsy and do an MRI every year on these patients.
Yes.
For 4 years,
For 4
correct?
years, yep.
So 200 patients?
Yep, 205 patients.
So great results. And so every time we put a patient on active surveillance, the thing that always comes to our minds is, do we really need to do a confirmatory biopsy? Because it's bothersome for the patient. Let's say the patient did a MRI fusion biopsy with an experienced provider. 1 year after, the PSA looks the same, the MRI looks the same.
Yeah.
Based on your results, do we still need
to do it,
a confirmatory biopsy?
Yeah, so the Miami MAST trial was really about looking at a lot of the more contemporary, more recent kind of technologies that we have in active surveillance. So for example, MRI, genomic tests, a lot of those were not included in a lot of the University of Toronto, Hopkins, older series, right? So this is kind of a more contemporary series that provides us that information. And we really have an ability to look at all these other things, molecular markers like the 4K score, other things, genomic markers, MRI, AI on the MRI. In the end, even if you have all those things, ultimately, I still think we're going to need confirmatory biopsies. Now, the timing may be different, right? So if you have a patient that never had an MRI and you get an MRI on that patient afterwards and it's negative and they had low-risk disease, you don't necessarily need to do the confirmatory biopsy right away, and you could probably go out to about 18 months to even 24 months. But if you have a patient that didn't have an MRI, low-risk disease, and then their MRI shows something, I would probably do that confirmatory biopsy earlier because I'd be worried about that patient having something that we didn't find on their diagnostic. So while I do think we are still going to be an era right now where we need it, the timing doesn't always have to be right away like it always used to be.
And the MRI can help us.
And the MRI helps us do
the
that.
timing.
Absolutely.
Right. Okay. Now switching gears to the follow-up biopsy. So we did the confirmatory biopsy. It showed basically the same, looks the same. Now this patient is on follow-up, and let's say how the MRI can help us in this way. And it's two ways, right?
Yeah.
So let's say the MRI looks the same. Do we still need a follow-up biopsy? Or on the other hand, the MRI got worse. Yeah. Do we need to trigger a biopsy early than we were planning? So how the findings fit into that?
That's a really good question. I mean, so, before MRI, we were doing biopsies almost every year because we needed to. And I think there's no doubt that MRI has helped us delay biopsies. But I don't think we're in a place here where MRI alone is allowing us to avoid them. So if the MRI looks the same, that's a good sign that hopefully nothing has changed, but you can't guarantee that. And while you may not necessarily need to do a biopsy every year, I probably do them anywhere from every 2 to 5 years, depending on how the patient is coming in. If they're coming in with a Gleason 7, I'll never go more than 2 years without a biopsy unless that patient gets older. Now, if they're coming in with a Gleason 6 and they've been okay on their biopsies and their MRIs are negative, I may let that patient go 3 to 5 years in between biopsies. But I'll always do biopsies, even if the MRI doesn't change, because you can't be sure that the cancer hasn't changed. Now, alternatively, if the MRI gets worse, that's what the Miami MAST was the ability to look at, is we were following up patients with MRIs every single year and biopsies every year. And we do see that if the MRI is worse compared to staying the same, you do have a more likely chance of progressing. However, there's significant false positives. So a lot of this could be a different radiologist reading it. Most times I think it's the fact that it scans, at least looking at to me, the scans may not look that different to my eye, but one radiologist called it this way, another radiologist calls it that way. So I think it just speaks to the variability in reading MRI rather than an actual change. So I personally think that that's where urologists should look at MRIs themselves. Absolutely. And they can be the arbiter for their patient to really say, do I feel that this changed or not? And in urologist's hands, if you don't feel like that MRI changed, then maybe it really didn't. Because a lot of these, MRI progressions, I don't know that they're real progressions, And what we've seen is, at least histologically on the biopsy, they haven't been. So So it's hard to say you're not going to biopsy someone whose MRI got worse. But at least from our experience on the MAST trial, most of those patients whose MRIs got worse, it wasn't their cancer that actually got worse. So,
but at least bottom line, the MRI can help.
It can help
Set how intense this follow-up will be.
Yes, but I think this is where the role of biomarkers, PSA density, hopefully AI on the MRI, those things will help us get to a point where maybe we can even get more closer to an imaging-based type of thing. Because patients would love to have an imaging-based thing where they look at the MRI alone and only do the MRI or the biopsy if it gets back.
Correct.
But we're not there yet. And I think at the point because of the issues with MRI variability, they will probably get biopsied more often than they need to because of the variability we see.
That's great. So thank you. Congratulations for the work. And appreciate your contribution here.